Good morning, everyone. My name is Dr. Renee Binder, and I am the director of the Psychiatry and the Law program in the Department of Psychiatry and Behavioral Sciences. And it is my pleasure this morning to introduce Dr. Omri Berger, who's going to be talking about an issue that I would imagine most people don't know much about, which is how do you treat inmates who are on condemned row or death row. So let me tell you a little bit about Omri. Dr. Berger received his bachelor's degree from the University of California, Los Angeles in molecular biology and neuroscience. And when he graduated, he received an award for academic excellence. He then attended medical school at UCSF, and he received the Chancellor's Award for Public Service, and he graduated AOA, which for those who don't know is the highest award that you can get on graduation. We were lucky to recruit him to our residency at UCSF. He received the Intern of the Year Award, and then when he graduated, he received the Edward F. Alston Award for Leadership. Then he did a forensic fellowship with us at UCSF. And as a fellow, he wrote an article on PTSD in the criminal courts, which when you look at the website of the Journal of the American Academy of Psychiatry and the Law, it's listed as one of the most read articles in the journal ever. So pretty important article. So during his forensic psychiatry fellowship, Dr. Berger worked at San Quentin State Prison, and then after completion of the fellowship, he accepted a position as a staff psychiatrist and has worked there since. And since 2013, Dr. Berger became one of the mental health providers assigned to work with the death row population at San Quentin. And he's been providing treatment to that population since that time. So I'm looking forward to hearing your presentation, Omri, as I'm sure everyone else is.
Thank you, Renee. Thank you very much for the very generous introduction. And it's, as Renee mentioned, I did most of my, all of my training, my medical training and psychiatric training at UCSF. So it's always nice to present to this department that feels like home. So as Renee mentioned, I'll be presenting on the psychiatric treatment of death sentenced inmates. I get some housekeeping first. I have no commercial ties to disclose. I am an employee of the California Department of Corrections and Rehabilitation, but the views that I present here may not necessarily or do not necessarily represent those of the department. And I also wanted to mention that I have some photographs included in the presentation, and all of those are from publicly available sources on the internet. I think I'll skip over the learning objectives that I think were included in the announcement, just for time's sake, for this presentation. In terms of what I will cover today, so by way of providing really background for the discussion of treatment services that are provided for death sentence patients at San Quentin, I want to provide a brief overview of capital punishment in California, and then describe the conditions of confinement for death sentence inmates at San Quentin. I think understanding both of those areas is helpful to understanding some of the challenges in providing treatment to this population. I'll then describe the treatment that's provided to this population at San Quentin, including some of the, again, challenges for mental health providers in this setting. And I'd like to then say a few words about the correctional setting as a training environment. Really, my interest in forensic psychiatry started as a medical student doing a fourth-year elective rotation with Dr. Binder in the Psychiatry and the Law program. And that really sparked my interest in this area and in correctional psychiatry. So I also want to, before I dive in, say a couple of words about terminology that I'll probably end up using interchangeably, just because there are different terms that can be used to refer to this area within corrections. So capital punishment and the death penalty, I'll probably use those terms interchangeably. Similarly, death sentenced inmates, death row inmates, condemned inmates are all terms that are used to refer to individuals who receive the death sentence. Death row and condemned row refers to areas within a prison where death sentenced inmates are housed. So I may end up using these terms interchangeably through the presentation. So to start with, I'll go over provide an overview of capital punishment in California. Capital punishment existed in California pretty much since California became a state in the mid-1800s. In 1972, the United States Supreme Court, in a series of cases, invalidated all of the death penalty statutes in the United States. So after 1972, the different states that had the death penalty began to pass new capital punishment legislations. And in California, the capital punishment was reinstated in 1978 as a voter-approved ballot measure, Proposition 7. And it's one of the reasons that for the death penalty to be overturned in California, it will require another voter-approved ballot measure. Executions didn't resume in California until 1992, initially by use of the gas chamber. And there were 2 executions by use of the gas chamber until in 1994, in the federal courts, the use of the gas chamber in California was deemed unconstitutional. California then changed the method of execution to lethal injection, and there were 11 subsequent executions by lethal injection between 1994 and 2006. And this is a photograph of the old gas chamber that was used at San Quentin, and it still exists. And this is a photograph of the lethal injection chamber, which also, again, still exists within the prison, but has been closed, as I'll mention in a moment. Now, starting in 2006, a number of legal challenges that mostly focused on the constitutionality of the lethal injection protocols effectively halted executions in California. So there have been no subsequent executions since 2006. And then in 2019, some of you may recall seeing this in the news, Governor Newsom instituted a moratorium on the death penalty in California by issuing a reprieve to all death sentenced inmates in the state. The executive order that the government issued at the time also halted all efforts by the state to overcome the legal challenges to the death penalty. Now, this didn't result in any changes to the convictions or sentences of death row inmates. And at that point, death row inmates still remained on death row. Also, individuals can still be sentenced to death in California despite this moratorium. And theoretically, a new governor can overturn this moratorium. So in terms of the size and demographics of the death sentence population in California, as of last month, there were 694 individuals sentenced to death in California. 22 of those are women housed at the women's death row, which is located at the Central California Women's Facility. 558 individuals are housed at San Quentin on death row. And the rest of individuals sentenced to death are either housed in other prisons under a recent change that has allowed the department to transfer death row inmates that have volunteered and that meet certain criteria to be housed in other prisons. That's a relatively small number out of the total number of individuals. There are also some individuals that are currently in medical facilities or in other jurisdictions, meaning they may have cases or incarceration in other states. So California's death row population is the largest in the nation. By comparison, Florida has 333 inmates on death row. That's the next largest death row population in the country. Texas has around 200 inmates on death row. In the United States as a whole, there are 2,455 inmates on death row in the country. So again, California has a large death row population in comparison to other states. And with respect to the age distribution of the death row population, as this graph shows, the majority of individuals who are currently death sentenced in California are somewhere between their 40s and 60s. There are some individuals in their 70s, 80s, and even one individual in his 90s. So it's an aging population, which, as I'll talk about a little bit later, certainly factors into the medical and mental health treatment of this population. And with respect to the racial demographics of this population, and this really parallels both the death row population within in the United States in general, and also the demographics of the prison population in general. The majority of death sentence individuals in California are non-white, and again, this table shows the breakdown. Oh, excuse me. And racial disparities in both the imposition of the death penalty and in the criminal justice system as a whole is a very complex topic that probably deserves a whole presentation in itself. It's also one of the main areas of criticism of both the death penalty in California and throughout the United States, as well as in the criminal justice system. So unfortunately, I don't think I can do this topic really justice with this one slide, but I wasn't able to include more information about it. Now, as I mentioned, the death row population in California is an aging population, and that's largely the result of the length of confinement on death row. So currently, the average number of years under sentence of death for inmates in California is 23 years. This length of time is a function of both the often decades-long appeals process that is mandatory for anyone who receives a death sentence. And just to put it in context, currently approximately 25 of the almost 700 death sentence inmates in California have completed their appeals. So again, the appeals process, which has several levels to it, takes decades. And in addition to that, as I mentioned earlier, there's the current moratorium on the death penalty. There have been multiple legal challenges that have slowed the process down. And again, this has resulted in this population being incarcerated for very long periods of time on death row, and then we'll discuss some of the conditions involved in the next section. And I think as this graph also shows, the majority of individuals who've been sentenced to death were in California, received their sentences in the 1980s and 1990s during a tough on crime period within the country. And then the numbers of individuals that have received death sentences slowly tapered in the 2000s, and particularly significantly tapered in the last several years. Now, the length of incarceration on death row in California, one of the results has been that the majority of deaths among this population have been the result of natural causes or suicide and not execution. So since 1978 in California, as I mentioned earlier, 13 individuals died by execution. 2 additional individuals died by execution in other states. So those are individuals that had death sentences in both California and another state. 108 died by natural causes. And that incidentally includes approximately 12 individuals that died due to complications of COVID-19 in 2020 during an outbreak within the prison and within the death row population. And 30 have died by suicide. The 15 that have died by other causes includes drug overdoses and homicides. So now I'd like to move to describing the conditions for those individuals that are housed within the death row unit at San Quentin. And for those of you that may not know, San Quentin is located about a 30-minute drive from UCSF in Marin County. It's near where the Richmond-San Rafael Bridge is. And the prison itself was first established in 1852, and it was the first prison in California. The prison is comprised of several housing units. The unit that houses the majority of the death row population is called East Block. It faces the east, and the red arrow points to that housing unit. This is the entrance to East Block, the housing unit, and the population, the death sentence population within this unit is completely separated from the 2,500 or so other inmates that are incarcerated at San Quentin. The death row inmates don't have access to the many rehabilitative and ward programs that are available to the rest of the prison population. And this population within the death row housing unit or the condemned unit is a maximum security unit, where the rest of San Quentin is a medium security prison setting. And this is a photograph from within the housing unit. This East Block was built in the 1930s. It has a maximum capacity of 520 inmates. And in this photograph shows one of 2 identical sides of the building. Each side of the building has 5 levels or tiers, and each tier has approximately 50 cells. The cells have bars and a metal mesh over the door, so sound easily travels into the cells, and inmates will often communicate with one another over distances. So it's often loud in the building, and which can be a challenge for inmates living in that environment. This is a photograph of what I would consider a typical death row cell. These are 6 feet by 9 foot cells. Each cell has, as you can see, a toilet and sink, a bed, a light fixture, and shelves, and a shelf. And all the death sentence inmates are housed by themselves, so they are not housed with cellmates. This is a photograph of an inmate in the cell, and much of the day is spent being locked in the cell. All meals are eaten in the cells. The food is delivered by custody officers to the cells. And as I'll talk about, there are some outside recreation time, but it's fairly limited. Inmates can also purchase some personal items that can include a TV, CD player, radio, books, magazines, art supplies, and extra food. Not all inmates can afford this kind of property, and it typically, because death row inmates typically don't have jobs and aren't able to earn money within prison, it typically requires somebody, a family member, for example, purchasing these items for them or providing the inmate with money to purchase these items. So some inmates have a lot of extra property, and others have very little. Because the housing unit for the death sentence inmates is a maximum security unit, whenever an inmate leaves their cell, they're first placed in handcuffs, and there are these cuff ports that are opened by the officer that escorts the inmate. The inmate is placed in handcuffs, and then the door of the cell is unlocked. The inmate is then maintained in handcuffs whenever they go between places, and an officer always escorts the inmate wherever they go. So this is a photograph of an officer escort an inmate, and this could be to a medical appointment or a mental health appointment or a visit, but all movement of the inmates out of the cell happens in this way. Inmates are provided, and this is similar to all prison inmates, are entitled to use a phone, and within the death row housing unit, at a minimum, inmates are allowed use of the phone for 30 minutes a week. Some use it for longer. In this photograph, it shows there's basically a phone on wheels that is moved in front of a cell to allow the inmate to use the phone. Inmates are also allowed kind of family or social visits, as well as visits with attorneys. Those typically happen on weekends. But since the COVID-19 pandemic, there have been, for the majority of the past 2 years, restrictions on in-person visiting. But the department has set up a way for inmates to have video visits in lieu of the in-person visits. In terms of outside recreation time, all inmates are given access to outside yard time at a minimum of 10 hours a week. Typically, those 10 hours are divided between 2 or 3 days, with in each instance approximately 3 hours outside. Some inmates have been determined to not be safe to be on a yard with other individuals, and those individuals have their outside recreation time in what are called walk-alone yards, which are pictured here. These are essentially caged in relatively small areas. And again, the inmate is escorted in handcuffs to the yard. The door of the yard is locked, the handcuffs are removed, and then the individual is able to have their recreation time in this way, their outside recreation time in this way. Other inmates are assigned to one of several what are called group yards. So these are fenced in, kind of half basketball court size yards where inmates can go out as a group. And it's an opportunity to be outside and to also socialize. Some inmates really go out on a regular basis and have a lot more opportunity to socialize. Other inmates, on the other hand, rarely go out to a yard and therefore have a lot more isolation, a lot less opportunity to socialize. So before I move on, I think probably the kind of take home points from with regards to the conditions on death row, I think the keys when it comes to the impact on psychiatric treatment is that there's really a fair amount of time spent alone, typically in a small cell with fairly limited stimulation. As I mentioned, all movement out of the cell, even outside yard time, involves a lot of having to deal with being handcuffed, being escorted, being placed in other confined spaces. And inmates often talk about the challenge of moving from cage to cage to cage at all times. So now I'd like to move to talking about the actual psychiatric treatment provided to this population at San Quentin. And it's difficult to talk about any mental health treatment in prisons in California without at least mentioning the Coleman class action lawsuit. And really a lot more could be said about this, but I'd like to at least mention it. So based on a US Supreme Court case from 1976, Estelle v. Gamble, adequate healthcare, including mental health care, was deemed by the United States Supreme Court to be constitutionally guaranteed to prison inmates, and not providing adequate healthcare to prison inmates constitutes cruel and unusual punishment. Now, in 1995, a federal lawsuit was brought against the California Department of Corrections on behalf of prison inmates receiving mental health treatment, alleging that the Department of Corrections was not providing adequate mental health care, thus violating the Eighth Amendment. The court in this case did in fact determine that the department was not providing adequate mental health care, and the court placed the California prison system under oversight when it comes to the mental health care that's provided. And this oversight by the federal court continues to this day, with court-appointed experts regularly visiting the different prisons across the state to assess the mental health care that's provided. This oversight by the federal courts led to the development really clear guidelines and higher standards for mental health treatment. So this was from a patient perspective and provider perspective within the system, certainly a positive change. It also really forced the Department of Corrections to increase the resources devoted to mental health care. One of the areas of court oversight has been specifically the mental health care of death sentenced inmates, particularly in the last 10 years or so. And this as well led to increased resources being devoted to the mental health care of this population. Within San Quentin, this increased resources for healthcare services led to the construction of a new hospital building in 2008. And this is a picture of the hospital building that's within the prison grounds. It includes extensive facilities for outpatient treatment, both medical, mental health, and dental care. And it also includes a 50-bed inpatient unit. And out of those 50 beds, 40 beds are devoted for psychiatric treatment, with the death row population receiving treatment within those inpatient beds. And I'll talk about that in a moment. In terms of the current treatment resources within San Quentin that are devoted to providing death sentenced inmates with mental health treatment, we have it in the prison divided into outpatient and inpatient services. The team of mental health providers that are assigned to provide outpatient treatment to this population includes 2 psychiatrists, which includes myself, 3 psychologists, 4 clinical social workers, and 2 recreational therapists. The services that we provide include individual therapy, medication management, group therapy, and recreational yard therapy. More severely mentally ill patients or more impaired patients are provided with more intensive treatment, probably similar to a partial hospitalization program or an intensive outpatient program where patients receive daily services, mostly in the form of groups, as well as weekly individual therapy sessions and at least monthly appointments with a psychiatrist. Individuals that are more stable are in a more routine outpatient level of care and may be seen anywhere from once a month to once every 3 months for follow-up. As I mentioned, there's also inpatient services provided within a 40-bed unit that includes really the cells in that inpatient unit are larger. It's a newer facility than the housing unit that you saw photographs of earlier. It's a cleaner, brighter environment, so certainly a more therapeutic environment. And within that environment, there are more intensive treatment services that are provided. The inpatient psychiatric unit provides both crisis treatment, which typically lasts anywhere from a few days to 10 days. Patients that need additional inpatient treatment are then can be provided with long-term care. And some patients have been within the inpatient setting for years. More typically, patients receive treatment for several months at a time within the inpatient program. Now, of the 558 death sentence inmates at San Quentin, approximately 200 are actively receiving mental health treatment. So not everyone receives mental health treatment. Of those 265 are receiving the more intensive outpatient level of care. And this is just estimates for the recent past, and approximately 15 are receiving inpatient services. Approximately 130 are actively receiving medication treatment. Of those, 15 are receiving treatment with clozapine. And 25 are currently on court order for involuntary medication treatment. So similar to the LPS laws in the community, inmates who meet certain dangerousness criteria or grave disability criteria and are deemed to lack capacity to refuse treatment we can obtain a court order for involuntary medication treatment. This is done in a court hearing. These orders are typically granted for a year at a time, and they can be renewed annually. The administration of involuntary medications can be a lot more complicated. So forcefully medicating an inmate within this setting can be a fairly involved process that requires prison staff, custody staff to forcefully remove an inmate from their cells. Generally, we've been very successful at avoiding those sorts of use of force and have been typically able to have patients voluntarily accept these court-ordered medications. As of 2019, treatment with buprenorphine also became available within CDCR, and currently approximately 40 of the death sentence patients are receiving treatment with buprenorphine. Other than that, substance abuse services are fairly limited for this population, and most of it is accomplished in individual therapy sessions or in group therapy. And these are some rough estimates of the numbers of patients receiving treatment for certain common disorders. My guess would be that if we were to be able to better screen the rest of the population that is not actively receiving mental health treatment, either because they're not seeking mental health treatment or they're not been identified as needing mental health treatment. There'll probably be higher rates of depressive disorders, maybe anxiety disorders, substance use disorders, and probably trauma-related disorders. So you can also see the rates of certain disorders like bipolar disorder and psychotic disorders are certainly higher than in the general population. There are also patients receiving treatment for personality disorders, primarily borderline personality disorder, a few patients receiving treatment for gender dysphoria, and a few for developmental disorders, primarily autism spectrum disorders. Suicide prevention is also a huge topic within the correctional setting, and death sentence inmates in particular have some inherent risk factors for suicide that have to do with both the sentence and conditions of confinement. I'll touch a bit more about it later, but again, this could be a lecture in itself or a talk in itself, the topic of suicide prevention within the prison setting. The rates of suicide within this population are significantly higher than the general population. And this would be a rough estimate. Again, patients currently receiving treatment that would be considered at high risk of suicide, who we provide closer monitoring of, be approximately 25. In terms of challenges, the many challenges to treatment within this setting, all the logistics involved in providing treatment in a high security setting presents a whole layer of challenges in itself. As I mentioned earlier, patients have to be escorted to appointments. Often when patients are brought to appointments, they first have to wait in these kind of holding cells or holding cages. Then another officer may bring them to their appointment. After their appointment, they may have to go back to wait in one of these holding cages before another officer takes them to their cell. So those kind of waits and all the multiple steps patients sometimes have to go to make it to an appointment can be a challenge and can inadvertently discourage patients from attending appointments. When patients go to appointments, they often have to be escorted across the prison grounds to treatment offices, such as in the hospital building. So again, a lot of time spent in handcuffs being escorted around. Now, when patients arrive at an appointment, whether it's an individual appointment or a group session, death row patients, and this is the same for other maximum security inmates within the prison, they're placed in the mental health office in what's called a therapeutic treatment module, which is meant to provide confidentiality as well as safety for the staff. And this is a picture of a photograph of an office with that has a few of these therapeutic treatment modules. This is in the prison's hospital building. And the patient is placed inside the treatment module. The door is locked, the patient's handcuffs are removed, and then the officer is able to leave the room, which then leaves the provider alone with the patient in the room for a confidential appointment, and the patient doesn't have to remain in handcuffs. This is a photograph of what group therapy looks like in this setting this is one of the group rooms at the prison where that is used for group therapy. It's amazing that it's possible to get used to, both as a provider and certainly as a patient, to get used to these security measures, but at the same time, it's certainly has a significant effect. And I think sometimes it's easy to underestimate that effect by becoming institutionalized to this setting and getting adjusted to this setting. But it certainly, I think, has a chronic impact on the patient's psyche. And many patients will comment about how they feel like they're treated quote unquote like animals by being placed in cages. And also some of the other and the psychological effects of being treated with these high security measures is that it often feeds into a patient's own view of themselves as being dangerous. When somebody's treated as being so dangerous, it's easy to adopt some of those views for patients of themselves. And I also think that for patients that have been living in these conditions for decades, there's really not been the opportunity to exercise things like self-control and self-regulation. And it's particularly true for patients who also, in addition to this, don't have, for example, these group yards to go to where they're around other people. So I think, in treatment, we often try to make it explicit and acknowledge and validate the impact that these security measures have. I think that's our best way to mitigate some of these effects. But again, that's certainly a challenge for, in particular for the patients, but also for the providers working in this setting. When patients decline to come to their appointments, which can be as much as half of the appointments in a given day, then we see the patients at their cell. This is a photograph from actually a media tour at the prison and with a reporter interviewing a patient, but this would be really the same for a mental health provider. So the mental health providers, we spend a fair amount of time talking to patients at their cell. Many patients prefer this because it's a lot easier than having to be handcuffed to leave the cell, to be escorted, to then sit in one of these therapeutic modules. So some patients prefer these, we'll call cell front contacts out of convenience, but confidentiality is an issue with these kind of contacts. They're usually neighbors next door that can easily overhear the conversation. So our ability to assess patients in this way is much more limited. At the same time, it does afford the opportunity to observe and assess how the patient is managing in terms of managing their cell cleanliness and organization. And this is particularly helpful for patients with more severe mental disorders. So as I mentioned, all of these security measures can inadvertently discourage patients from attending their appointments. And they're really also, we have to keep in mind that they're necessary but inherently dehumanizing, and how to attend to that in treatment. There's also a lot that could be said about the cultural factors that present a challenge providing treatment within a prison setting. In particular, stigma about mental health treatment is probably more significant than in the community and is seen as weakness within this setting. And within certain prison gangs and groups, it's receiving mental health treatment is taboo. I could say a lot about this, but I'll move forward. But prison has its own culture that can be very difficult to develop competence in that culture and the culture of this setting, particularly for anybody who's not had exposure to this setting before. And many of the values and rules of the prison environment are things that as providers we would consider to be maladaptive or antisocial. So having cultural competence and understanding the prison of culture often has to be balanced with therapeutic challenging some of the cultural values that inmates live by. There are also common kind of transferential challenges for providing treatment within this setting. There is an inherent mistrust in authority figures and in the system as a whole, and treatment providers are often seen as parts and members of this greater system. Patients often expect providers to judge them based on their crimes and based on their sentence. With that comes an expectation from patients that providers may be punitive or neglectful, and sometimes things such as giving patient necessary involuntary treatment can be easily perceived by the patient as punitive or as mistreatment. And there's also this population has often had negative experiences either before incarceration and during incarceration with mental health providers and even through their trial process. As a provider, it's not uncommon to experience things like fear and intimidation from patients. Sometimes in developing a clear formulation of the patient, we do have to learn about their commitment offenses, for example, and that can be something difficult to integrate and manage counter-transferentially. Manipulation is very common within this setting because it is patients often expect neglect and mistreatment. It's not uncommon for individuals to use manipulation to try to get reasonable needs met. So not understanding that that kind of manipulative behavior can certainly weigh on or engender negative countertransfers in a provider. And it can also be challenging within this setting to how to both understand, but at the same time, not be impacted by all of the external attitudes by society, by victims of the crimes of some of these patients, by custody staff, to not be influenced by all of the varying attitudes about this inmate population. In terms of how to, at least strategies that I've found are important for overcoming a lot of these barriers to treatment, particularly the transferential and counter-transferential barriers. Really, it's probably pretty basic and similar to other settings, but really paying a great deal of attention to rapport building, to the therapeutic alliance, because of the inherent mistrust in this population that I mentioned. Transparency, honesty is very important, and really using a lot of validation. There's a lot that we can change for the patients, but validation goes a long way in a fairly invalidating environment. I'm going to skip a couple of slides because I'm a little short on time. And this is just, I have a couple of slides on the challenges of providing treatment in the custodial setting, but I'd like to move to talk about some of the clinical challenges in this setting. So I think one of the, in providing clinical care in this setting.
It's almost 9:20. I'm sorry to interrupt, but I just wanted
to. There's a lot to talk about in terms of how to help patients and treat patients when it comes to the impact of the conditions of confinement. And I apologize that I'm running out of time, but I'll skip the slides here to maybe talk about some of the existential factors. And I think this is probably one of the areas we spend the most amount of time on with patients. And this has to do with how to help patients manage multiple and pervasive reminders of mortality, the sense of meaninglessness and purposelessness that exists for patients living in this environment, the loss of freedoms. For many patients, regret and guilt, not regret and guilt that's necessarily part of a depressive disorder, but regret and guilt about real things can be very challenging to deal with. And some of the demoralization and suicidality that may emerge in this setting, again, not as a result of a mood disorder, but because of the conditions. So some of the strategies that we use in helping patients with these issues around death anxiety, the highlighting to patients the universality of death. This may seem pretty basic, but for death row patients, it's sometimes hard to keep in mind that we're all subject to the same mortality, and for some patients that can be soothing to talk about that. Using the awareness of mortality as a motivation to live in a moment and search for meaning. Helping patients realize that there's a way to piece together meaning from small things in day-to-day life, and looking for meaning in growth and change. helping patients identify areas of control and freedom, and most of those are internal, really helping patients recognize their controlling choices they can make with respect to their perspectives and attitudes and the way they choose to react to their environment. And guilt, patients often find it helpful to try to just develop an understanding of why they may have done the things they've done, and really trying to achieve sort of a non-judgmental, objective understanding of that. In many cases, accepting feelings of guilt and regret is a sign of rehabilitation of their humanity, and helping patients find ways to make amends by really trying to change the things that have contributed to their past behaviors. It's also very important in this setting to discuss suicidality openly. I think patients often are worried that providers will overreact if the patient mentions the word suicide. So creating room for patients to discuss that within this setting as an understandable effect of the environment can really help with suicide prevention, helping patients identify sources of hope and optimism, realistic ones, and directing patients to find ways to find meaning. And, sorry that I had to skip over this part pretty quickly, but I do want to mention that doing this work, I've found certain readings by Irving Yalom, the Existential Psychotherapy book, to be extremely helpful. I've learned a lot from it in ways that I was able to directly apply to this setting. Similarly, Viktor Frankl's Man's Search for Meaning and some of his other works, I often will provide those readings to patients in this setting. They find that very helpful. And some of the wisdoms, this is one of my favorites. Everything can be taken from a man, but one thing, the last of human freedoms, to choose one's attitude in any given sort of circumstances. And a lot of, I find the work that we do really revolves around this kind of thing about when a situation is unchangeable, how to help an individual confront it in the best way possible. So I think I'll pause here. I didn't get a chance to say as much about training within this setting, but for any trainees interested, I would welcome you to contact us and consider rotating through our site. We benefit just as much from having trainees. So I will leave this up with my email address for anyone that wants to contact me, and I'll take any questions.
Omri, thank you so much for the fantastic presentation. There's a little static on your end. I wonder, in answering the questions, if you could try with your headphones just to answer.
Sure.
We can hear everything, but it's a little staticky. Let me go over some of the questions. So one is from Rob Daroff, who I'm sure you know well. And
Yes.
Rob wrote, powerful presentation, Omri. Thank you for doing this important work. Speaking of stigma, it seems like prison work is stigmatized within psychiatry, and I presume prisons are chronically understaffed. Given all of the challenges, can you talk about what is gratifying about this work and what has kept you going for so long?
It's a great question, and most prison settings are understaffed, which I think is a challenge. At San Quentin, we're pretty lucky to be fully staffed. I think one of the things that for me has been key in being able to do this work is the really great leadership we have at San Quentin. So Dr. Paul Burton, who's also a graduate of the forensic psychiatry program, is the chief psychiatrist and really champions mental health care and psychiatric care within the prison. And I think that's one of the critical factors. It's not a setting that has healthcare as its mission. So it's really important to have the kind of leadership that supports providers in providing care that feels good. I certainly enjoy this work because it is an underserved population. There are many people within the prison environment that are receiving mental health treatment for the first time. And many feel that if they had mental health treatment earlier, they would not be in the circumstances that they're in. So to me, that's one of the most gratifying aspects of this work.
Thank you, Omri. We have a question from Michelle Porsche, who asks, what is the receptivity of the prison staff to training on psychological therapeutic constructs that might improve work with inmates in coordination with clinicians?
I'm assuming that's in terms of custody staff, so non-mental health staff. If that's the question, it's come a long way historically, and I kind of had to skip over this. It's a setting where conflicts can easily arise in the perspectives of mental health staff and custody staff. Some of the goals can seem to conflict with each other when it comes to mental health treatment and providing security within this setting. But what I've found over time is that there's real opportunity to collaborate by focusing on the ways the interests align. So in most cases, when patients are psychiatrically stable, the environment is safer for staff. I think I've seen over my time at the prison that most custody staff really recognize that and embrace the presence of mental health providers. And really a lot of the, what alerts us to situations where patients are decompensating is custody staff being proactive, reaching out to mental health staff and enlisting our help.
Thank you. We have a question from Edie Harris, who introduces herself as a clinical psychology trainee with an interest in working in prison settings. Do you have any suggestions of training opportunities with these patients?
So there is a psychology internship program, for example, at San Quentin. That's one program I'm familiar with. You're welcome to contact me and I can try to connect you with the people that direct that training program. But I think as for me, doing clinical rotations that are available for me was through a medical school rotation that first exposed me to this work and sparked my interest. You're welcome to contact me and I can try to get you more specifics.
A question from Andrew Sudler. Thank you, Dr. Berger, and this will probably be our last question. Thank you, Dr. Berger, for this presentation. There was an article in the news yesterday about how the California government is attempting to close San Quentin's death row unit by moving individuals on death row into the general prison population and turning the previous death row unit into a more healing environment. How do you think this will impact your work caring for patients on death row in correctional settings?
So I learned about this as well through the news yesterday. Certainly if this were to happen, as I hopefully was able to convey in this talk, the conditions are a significant aspect of what affects patients' mental health within this setting. So if patients were able to move to other settings that are less restrictive, certainly that would, I think for many, be an improvement. But hard to say before we know more. Again, I just learned about this yesterday myself.
Okay, I think we'll stop there. Thank you so much, Omri, for a wonderful presentation about a topic that most people don't know anything about, which is, of course, one of the big purposes of Grand Rounds. So, and thank you for your very inspiring work with this underserved population.
Thank you.